Muy buenas noches a todos ustedes. Quiero darles la bienvenida a todos ustedes para esta sesión que es parte de nuestro programa internacional. El día de hoy, bueno, más bien esta noche, tenemos el gusto de presentar a la doctora Cara de Meister de la Universidad de Stanford. La doctora es profesora asociada en la división de otorrinolaringología pediátrica, es experta en el tema de cirugía endocrinológica por la Universidad de Stanford. Y también tenemos el gusto de tener esta noche aquí con nosotros al doctor José Antonio Orozco Morales. El doctor José Antonio Orozco Morales tiene maestría y doctorado en ciencias. Él va a fungir como el coordinador esta noche y es además el jefe del Departamento de Endocrinología del Hospital Infantil de México, Federico Gómez. Creo que tenía un poquito de problema el doctor, andaba en el tráfico. Vamos a ver si ya es factible que se pueda conectar para estar aquí con nosotros. Y si no, bueno, va a empezar la doctora Meister con su ponencia y el doctor José Antonio se unirá a nosotros en la sección de preguntas y respuestas. Doctora Meister, si gusta comenzar, muchas gracias nuevamente por estar esta noche aquí con nosotros.
Absolutely. Thank you for having me. My slides are going to take just a minute to pull up. So, good evening. Thank you so much for this kind invitation to speak about one of my most favorite and beloved topics, which is thyroid pathology in children. And it may seem a bit odd to be so excited to talk about this, but I really think it's an area of medicine where we as pediatric otolaryngologists have so much to offer and also so many great ideas of how to treat these children better in the future. I don't have any financial disclosures. I don't speak very good Spanish. It's quite poor, actually. And so I did employ ChatGPT to both help translate this slide as well as generate this photo of a patient getting a thyroid ultrasound, which I thought was quite cute. So. Our objectives for this evening are to review the characteristics and management of children with thyroid masses and well-differentiated thyroid cancer, as well as discuss hyperthyroidism in the pediatric population. Thyroid masses are most often discovered incidentally, either by routine physical exam. I see many children who were seen by their pediatrician or family physician and for their baseball physical or their soccer clearance, and a little lump in the neck was noted. We also see many children who are getting imaging for something else, either after a trauma or for something else in the neck or chest, and a thyroid lesion or a mass in the neck is discovered incidentally. Many malignant nodules also present as asymptomatic cervical metastases. That's not uncommon. And there are many other mimickers of thyroid pathology in the neck, including abscesses, lymphatic or vascular malformations, ectopic thymus, thyroglossal duct cyst. All of these can mimic thyroid nodules. A key point is that the incidence of a nodule in the thyroid in children is actually quite low when we compare that to adults. So in children, less than 10% of our pediatric population will have a thyroid nodule. as compared to adults, where depending on the age of that adult, half to even upwards of 70 to 80% in our elderly patients will have a thyroid nodule. Our young adults and adolescents are somewhere in the middle of those two populations. Now, if we overlay the chance of that nodule being malignant, that's what these blue bars are showing. Now, what that means is that if a child has a nodule, while it is more rare to have that nodule, there is a higher chance, upwards of 30%, that that nodule does harbor malignancy. And so that is why we're very thorough in evaluating any thyroid nodule in children. To put it with some numbers behind it, again, the incidence is quite low, but the chance of that nodule having cancer in it is much higher than the adult population. A key difference in thyroid cancer in children is that it is often multifocal. And I'm interested to hear Dr. Orozco's comments, but what we see clinically in our patient population is that the younger a child is, the more likely they are to have multifocal disease. And so this influences my management because I'm often more aggressive in offering total thyroidectomy in our prepubertal or near puberty age children. Thankfully, in children, the 20-year survival is upwards of 95 to 98%. And so that's important because it gives us really a lot of responsibility in the ethos of doing no harm, right? So if these children are going to do well from a survival standpoint, we also need to protect their quality of life. A key point is that the incidence of thyroid cancer is higher in children with thyroid nodules than adults with thyroid nodules. How do we evaluate thyroid nodules in my practice? I use an algorithm very similar to this one. There's also one published by the American Thyroid Association. And most importantly, we start here in the first box. And as you will see, the first branch point is to get laboratory studies. We always get a thyroid stimulating hormone, a free T4, as well as a T3. Clinically, I often also get thyroid globulin antibodies, thyroid peroxidase antibodies, and vitamin D levels. I only choose to get calcitonin if there's a family history of medullary thyroid cancer. I often want to know if there's a family history of any thyroid problems or thyroid autoimmunity. Many of our patients actually with thyroid cancer have this on a background of thyroid autoimmune disease, and it can be really tough sometimes in those patients to both interpret the ultrasound of the thyroid as well as their cervical metastases, because the neck ultrasound and the lymph nodes in autoimmune thyroid disease can be enlarged and look concerning, but actually just be consequent of the autoimmune process and not malignant. If there is a hyperfunction on the labs, then I proceed with a radio uptake scan. And if there's no hyperthyroidism, there's no indication for our nuclear medicine scans. In bold, you'll see the first step in our workup is always these laboratory screening studies, and often the last step is ultrasound, and we use ultrasound quite freely in my patient population. Why do I love ultrasound so much? It is key, really, in evaluating, screening, and in the surveillance of benign and malignant thyroid nodules, as well as diffuse thyroid disease and congenital anomalies. It's cost effective, it's non-invasive, I can get it without any sedation or drama. I do my own both in clinic and in the operating room, but I also loop in my radiology colleagues because they take a different slant. Our group has recently looked at utilizing artificial intelligence to classify thyroid nodules, and not surprising, it did better than our human eyes. And so I look to incorporating AI actually into clinical use as a next step in that project. Moving on to pediatric thyroid cancer. Pediatric thyroid cancer may be increasing in incidence based on the US cancer surveillance data from up through 2013, which is the most recent analysis. It did show about a one and change % increase per year. The peak incidence is really in that post-puberty adolescent age group, 15 to 19 years old, especially in girls. Younger patients, those who are pre-puberty, do have a higher risk of distant metastases than our older patients. And this is related to their genes. So the genetic drivers in patients who are getting thyroid cancer earlier versus children who are getting it later, this is a genotype that drives a phenotype, and we'll talk a little bit more about that. Again, as I mentioned previously, it is often on a background of thyroid autoimmunity, and I would love to hear if we think this is a chicken or an egg, right? So is it the thyroid autoimmunity that then predisposes to the thyroid malignancy, or is it the malignancy that happens first and then the body responds and you see evidence of that response as thyroid inflammation? I think the jury is still out on that. Here is our study looking at that the US SEER database. I included it here because in California, where I'm based, the California reporting is mandatory by the California state government. And so we actually make up about 60% of this US database. We have a higher than the rest of the country incidence of a Hispanic population. And when we kind of drill down on this, we actually see that a lot of this increase in overall incidence is driven by Hispanic females. Looking at some of the other social determinants of health as a follow-up study to that initial study, we also saw that male sex was associated with a decreased overall survival and disease-free survival. The overall presentation in non-Hispanic Black patients was more advanced, and a larger tumor size, or T stage, was associated with Hispanic, non-Hispanic, Black, and Asian children. And similar to the adult literature, social determinants of health have been linked to more advanced thyroid cancer stage at presentation. And so following this, we wanted to figure out, well, why might that be, right? Is it truly an access issue? Is it a knowledge issue? Or is there something in the biology that's different in these different genetic populations? And so we followed up that paper looking in a slightly different database, but the incidence of biopsy and the disparities of a patient being recommended or having access to biopsy when they have a thyroid nodule. And so this was around 12,000 nodules. About 20% of them went on to get a biopsy. And what we saw is that indeed Black and Hispanic patients were less likely to receive a biopsy than white patients, which may actually represent a diagnostic disparity that then leads to that larger tumor size at presentation, because it may take them longer to get into the queue to get that biopsy. So a key point is that in our US data, the highest increase in incidence of thyroid cancer is in Hispanic adolescent females, whether that is something driven by a thyroid autoimmunity, something in the environment, something in the genetics, or something, a quirk in the reporting mechanism. I am not sure, but it's an interesting question, and I think a salient finding worth sharing with this group. when we are thinking about those genetic drivers, a key difference in the pediatric population is the concept of a fusion oncogene. So rare in adult tumors. In adult tumors, we're thinking more about BRAF valine 600, point mutation, RAS point mutations. But in children, many of them will have fusion mutations. This is an older paper from 2017, wherein they reported that about 60% of their cases had a discovered genetic mutation. I would say that in my practice, where I'm very lucky and I realize I'm very fortunate to be able to offer both molecular testing on the tumor as well as germline testing for the patient on every patient that we see, our incidence is actually much higher. And our standard clinical practice is that we offer both point mutation analysis that is a DNA based, as well as fusion genetic analysis on every thyroid tumor that we see, and sometimes on nodules that are atypical. Nonetheless, the importance of these fusions is that they are often associated with a larger tumor size, multifocality, younger age, and really aggressive cervical and pulmonary metastases. And so I can almost, at this point, 10 years later, I can almost guess when I see a patient of what if they will be fusion positive or point mutation positive. And I think that's really interesting because as we discover more and more about the molecular landscape of pediatric thyroid disease, and in parallel, as we really are entering this age of precision medicine and alternate therapies for treating all types of malignancy and immune dysfunction, I really believe that we will see a paradigm shift in how these patients are treated. For example, our TRK fusion mutations are pretty common in children, especially in metastatic disease, as previously mentioned. It's harder to really associate it with higher disease stage because there's just not a lot of granularity there. But a key point is that the molecular landscape of pediatric thyroid cancer is really being defined, and fusion mutations are common and often present as more invasive disease. And I really believe that in the not so distant future, our management may be stratified by genetic information. And so why are children different than adults? Well, they have different genetic risks, right? They have different medical risks. Hypocalcemia, permanent hypocalcemia in a 6-year-old is a really big deal. They have different outcomes. There are different operative risks. And we, as mentioned earlier, have different goals in therapy. So we know these kids are going to do well. And it is our burden and responsibility to really maintain that low disease-specific mortality while reducing potential complications from therapy. And so moving on to a little bit more of the specifics of pediatric thyroid cancer, 90% plus are papillary thyroid cancer. Again, frequently multifocal and locoregional metastases are in a majority of patients at presentation. The chance of pulmonary mets may be inversely related to patient age, and it does seem to increase with tumor size, extrathyroidal extent of disease, and the burden of neck disease. Bone mets are rare, but we do see them occasionally, as are brain and liver mets. Again, very rare, but if I have a patient who has a large biochemical response that we can't explain otherwise, those are two areas that I keep in the back of my mind to evaluate. Follicular thyroid carcinoma in children is quite rare, being less than 10%. In general, it's less aggressive than papillary thyroid cancer with less advanced disease. It's generally unifocal with a decreased tendency to spread, although it is prone to homogeneous metastases. The overall landscape of the mutational profile is more unstudied, and this is related to just a smaller sample size. But if you have a patient with follicular thyroid carcinoma in the pediatric age range, you should have a high index of suspicion for an underlying PTEN mutation in children with this disease process. We found a handful of patients with undiagnosed PTEN hammer tumor, Cowden syndrome, who initially presented as follicular thyroid carcinoma. And so, again, I think it's our opportunity to be able to really get these children in with the geneticist if that is available in your patient population. I want to talk briefly about patient L. So this is a patient that came to see me after her sister was diagnosed with Hashimoto thyroiditis, and then mom noticed that, hey, her thyroid's kind of large too, so maybe she should get something. So she was screened with an ultrasound by a very astute pediatrician who ordered both an ultrasound and baseline labs. I will say that one thing that often surprises me when I go speak with the community or as I'm reviewing referrals that come into our thyroid center is that there is a common misconception in the pediatric population that if the thyroid function tests are normal, then they don't warrant an ultrasound because there is this misconception that thyroid cancer would alter thyroid function, when in fact most of our patients, the vast majority with thyroid cancer, actually present with normal thyroid function tests. And I think that that's something that we are really obligated to educate our referring physicians about. So this patient did have normal labs except for elevated anti-TPO antibodies, which was not surprising in the setting of a family history of Hashimoto thyroiditis. And her vitamin D level was low, which at the year this patient presented, everyone's was low because we were still in the midst of COVID-19. And this was her ultrasound. So, overall, it looks a bit heterogeneous. It has this diffuse looking echo texture. It's a little bit hard to outline the borders. And in this left lobe, one could argue that this is a pseudo nodule, meaning not clearly defined borders, but there were enough areas of suspicion, including this more solid area, the complex both hyper and hypoechoic features of this nodule, and maybe a few blushes of microcalcifications as well, more inferiorly. Hypervascularity has been kind of a controversial indicator of thyroid disease, but I think, of thyroid malignancy, but it is something that it still catches my eye when I see it. And then most importantly, there's this shot where you can see trachea, we can see the thyroid, we see the great vessels, and then there seems to be something just on the edge of the screen out here. And what I think the point is in this slide is to remind ourselves that if we are suspicious of a thyroid, if we're getting that thyroid ultrasound to evaluate a nodule, for example, it does behoove us to really examine all levels of the neck bilaterally to do lymph node mapping, because that may influence your interpretation of the disease. And on that note, it's very common for thyroid nodules to be hypoechoic, to have those irregular margins or increased intranodular blood flow when there is a focus of malignancy. Very suspicious features include microcalcifications and, again, the appearance of adjacent abnormal cervical lymph nodes. If the nodule is suspicious, again, really emphasizing getting that cervical ultrasound, and our American Thyroid Association guidelines do recommend ultrasound guidance if an FNA is pursued in the pediatric population. And at least the 2015 guidelines, we're still waiting on the updates. The 2015 guidelines also ask that the cervical lymph nodes are tissue biopsied by FNA prior to offering a lateral neck dissection. It's not necessary for the central neck, but if you're going to offer lateral neck dissection, it's best to have pathologic confirmation either by FNA or thyroglobulin washout. It's our standard to get both at the same time. I'm often asked if we use molecular testing for thyroid nodules. When I meet with families, I always discuss, we're going to get a biopsy of your thyroid. There are 6 different possible answers. We could not get enough. We could get a good answer, we could get a bad answer, we could get somewhere in the middle that's a gray zone. If we get that gray zone, there are some other tests that we can do. And so a few comments on these germline mutations. So they were based on the adult population. They've never been validated in the pediatric population, which, 20 minutes ago, we just said has a completely different positive predictive value and negative predictive value of thyroid cancer, right? It's closer to 20 to 30% risk at baseline versus an adult nodule, which is much lower. So we're already starting at a different playing field, and they have different genetic drivers. And so while I do often offer this, you have to take the results a little bit with a grain of salt. And I use it more to confirm suspicion. If the genetic testing is negative or is not able to be completed, I don't equate that to meaning that there is not malignancy there, okay? But I have found it to be very helpful. And again, these are things that we think about when we're extrapolating the adult experience onto molecular testing, and that is, what is the positive and negative predictive value in children and adolescents, and how do we think about this in a population who may have a germline mutation or a cancer predisposition syndrome. I did my residency training 6 long winters at the University of Pittsburgh in Pittsburgh, Pennsylvania, which is an amazingly beautiful city if you ever have a chance to go. It is the steel city, and so in many, in a different era, Pittsburgh was an industrial city. It was known for steel production, and so their football team is the Steelers, and the motto of the otolaryngology residency is "heal with the steel," which I'm sure doesn't translate well, but has always stuck with me throughout my surgical career. And so the initial surgical approach really is your opportunity to heal with steel. It is the greatest impact for the risk of later recurrence. I either perform a flexible laryngoscopy or an ultrasound evaluation of the vocal folds to document vocal fold movement prior to surgery if I'm suspicious of malignancy. And I personally have really a low threshold for cross-sectional imaging. I pretty freely will get a CAT scan of the neck, and at the same time often get then the CT of the chest on the same day preoperatively. And the reason that I do that is because I find that sometimes ultrasound can miss disease if it's, behind the esophagus, if it's in that retrocarotid space. Retropharyngeal nodes can be difficult to see, and sometimes just the way the patient is seated, if you're not actually moving the patient to do the ultrasound, level 5 can be overlooked as well. And so in our institution, we have adopted a lymph node mapping that we use for our ultrasound techs to really try to be consistent and comprehensive. But I have a low threshold to get cross-sectional imaging. Many of our patients travel from a distance, and so getting that CT at the time of their diagnosis really helps me to think about if they do need other therapies such as radioactive iodine, do we need to do it at a dose that would be appropriate for known pulmonary metastases? And we've looked at our data internally, and when we compare pulmonary metastases detected by CT versus on initial whole body scan prior to RAI, and then post-treatment iodine imaging, there's a huge discrepancy with CT being much more sensitive, at least at our institution. You all know this, but there are risks to surgery, most commonly bleeding, hypoparathyroidism, nerve injury. Um, I use a pediatric nerve monitoring tube. It only goes down to a size 5. So in our little tykes, especially our medullary thyroid cancer or syndromic children with a prophylactic thyroidectomy, we use a butterfly electrode. I use a post-operative PTH level to drive management. And just a reminder that children less than 10 are a different beast. They're at more risk. They have often more aggressive disease, and their rate of surgical complications is higher. And so it doesn't mean that we shy away from those patients, but I give myself extra time. I make sure that I eat a big breakfast that day. Those are really high level cases. And this is my partner in crime. This is Dr. Gary Hartman. He is a pediatric surgeon who did all the thyroids before I joined him almost 10 years ago. And now we have the honor and pleasure of doing them together. We learn from each other, and he's been an amazing mentor and friend while I've been at Stanford. So and I was quite young and 3 children ago there. So um, some kind of more innovative things that we are doing is mixed reality. So I'll play a video on the next slide. I'm going to turn the sound off because our resident, who you'll see on the right, she's talking to our one of our advanced practice practitioners, and they are seeing an avatar, which we can't see looking at this, but they are looking at a tumor as an avatar and really walking around it 3D to be sure that they are on the same page, that they understand all of the structures. So let's play this. Hopefully you're seeing that video.
Wait, Carly, are you?
Sorry. So they're seeing an avatar that we created of a mixed reality and able to really walk around this very advanced tumor that invaded many things that it shouldn't. It was quite a rude tumor. And so we're doing more and more of that, both for training and disease planning. Um, I mentioned earlier that I feel very lucky and fortunate to have a great genetics team in an institution that supports molecular testing and germline testing. I know that that's not the case in every clinical situation, but what we do see is that at least in our population, there are inheritable forms of thyroid cancer, which account for 5 to 10% of thyroid malignancy. And I have found that even when the tumor testing is negative, every now and then we will still find a discoverable syndrome on germline testing. And so if I have a very young child and we don't find any hits on the tumor, I will often still send them to genetic counseling to see if the family would like to proceed with germline testing. And the case that kind of led me to that is this child. She was a 10-year-old girl when I met her. Family had a known history of multiple endocrine neoplasia syndrome. She had a moderate risk mutation. She had been tested when she was very young at 5 years old, and then had a new PCP, and she came in with the sore throat and neck pain. A very astute pediatrician ordered thyroid function test as well as a calcitonin, which was essentially off the chart for detection. It was nearly 15,000, with the reference range being less than 6 as normal. And so when she came in, she had very, very advanced medullary thyroid cancer that completely encased her right carotid. So you can see the carotid here. You can see this tumor just completely encasing. It was almost coming through the skin. And when you spoke with her in clinic, she had a little bit of stridor. It wasn't high pitched, it was deep and biphasic. And so we took her for her resection, and at the beginning of that resection started with a bronchoscopy. And you can see on these endoscopic photos, here are her vocal folds, and then distally, this is abnormal. And as we get closer and closer, no, she really had fourth degree invasion through the tracheal wall, intraluminal medullary thyroid disease. And so at that point, I knew that a resection, both of her trachea, her thyroid, her central neck, and her lateral neck concurrently would really put her at risk, as well as wanted to get more information about that carotid artery. And so we aborted her surgery, and we thought really hard about what to do. And we actually treated her in a different way. I bring up her case for a few reasons. The first one is, if we look at where she is, so she had a moderate risk mutation, and she had presented very early compared to her other family members. And so when we sent her tumor off for testing, what we found was a second hit. She also had a baseline diagnosis of Fanconi anemia, which may explain why she presented so aggressively. So we started her actually on vandatinib, which is a tyrosine kinase inhibitor, RET inhibitor, and she tolerated it beautifully. She really came down, and then we offered surgery about 4 months later. It was a much easier operation. Her tracheal disease had completely regressed. We did not need to do a tracheal resection. I left a little bit of disease around her carotid artery because she had failed her balloon occlusion test, which was also a trip in a 10-year-old. But she has been doing really well with a stable biochemical level of disease. And the big question now is, when, if ever, are we going to be able to wean this tyrosine kinase inhibitor? And so more and more we're seeing this pop up in the literature, both at different points in that treatment algorithm as an option for treating aggressive thyroid cancer in kids. And so as we round out the discussion on thyroid cancer before we move on, I think that for so long, the model of thyroid cancer treatment has been surgery first, radioactive iodine, and then everything else, including maybe targeted therapy. And in the future, I strongly believe that that's going to change, and there will be patients that get targeted therapy either upfront or in the middle of this or after radioactive iodine. We have a long way to go to understand how long to keep patients on it. What does weaning look like? How do you need to stop it before radioactive iodine treatment, et cetera? And so we've treated about 5 patients with tyrosine kinase inhibitors for different disease processes at Stanford Children's, and I look forward to the next 10 years where we understand a little bit more about this. Again, I think targeted therapy prior to radioactive iodine is an area that's we're going to continue to see more and more of. This is from our colleagues down at MD Anderson. And what I love also about this paper is it really shows the multidisciplinary nature of taking care of these kids. And speaking of that, I'm so lucky to have an amazing team. And recently we were able to publish our experience and our thoughts around what do you really need to take care of these kids, and who are the core members of that team if they're not at your own institution that you can have kind of on speed dial to be able to discuss these kids. And not surprisingly, those described as core members were endocrinologist, thyroid surgeon, either an otolaryngologist or a general surgeon, a nurse coordinator, someone who can do an FNA, right? A pathologist, and pediatric nuc med. And also highly valued members of the team include radiologist, social worker, oncologist, and really the geneticist or genetic counselor. And I would like to emphasize these two key points that the management of advanced thyroid cancer is really evolving, and the roles of surgery and radioactive iodine may change. And we need dedicated teams to answer these questions, because the surgeon's always going to want to operate, and we really need to understand if we can make our lives easier and our surgery better by collaborating with our colleagues to do the best for the patients. The last thing I'll say really about thyroid cancer is that we have a survivor clinic at Stanford Children's, and I see a lot of patients from that population. Our kiddos who are treated for either ALL or AML or other disease processes that undergo either whole body irradiation or our sarcomas and other primary brain or neck pathology that get neck radiation do have a very high incidence of both hypothyroidism as well as thyroid structural differences like thyroid cancer and thyroid nodules. So always be suspicious of these kids. We are doing a little bit of radiofrequency ablation for benign disease. I've done a whopping 6 cases to date. We did 2 lingual thyroids and we've done 4 nodules. The patient has to have 2 biopsy-proven benign diagnoses before I'm comfortable offering radiofrequency ablation. I do it in the operating room and under anesthesia, both for the patient's comfort as well as my own learning curve. And we're lucky to have an institution that supports this. And we'll see what the future holds. I think that there are indications, but those indications are evolving. So far, we have not had any complications. 3 of our 4 children with benign nodules had a very good response. 1 had a less than positive, a fine response, and the lingual thyroids have done very, very well. So. And then moving on to hyperthyroidism. So pediatric Graves' disease is the most common cause of hyperthyroidism in children. Also some controversy on whether or not it may be rising in incidence. We tend to see a more severe presentation the younger the child is. It's important to understand if there's a family or personal history of autoimmunity or conditions that may predispose to autoimmunity, such as Down syndrome, DeGeorge syndrome, Turner syndrome. And it's also important to document their diagnostic criteria, such as any symptoms, if they have a goiter, lab results, especially, and eye disease. The management of pediatric Graves' disease is really based in medical therapy. So medical therapy is almost always first line unless the patient has a very severe presentation from their Graves. Antithyroidal drugs plus symptomatic control as directed by the endocrinologist in our care setting. Most often patients will stay on for 1 to 2 years, but if they're tolerating it, tolerating the medication and are adherent, we do offer them to continue. I have a patient that's been on methimazole for 10 years actually. So she's getting ready to go to law school in the fall and finally just had an ultrasound with a nodule. That nodule came back as an atypia, and they were not able to run genetics, and so she may soon be without her thyroid, but still considering it. And so I bring her up just to say that we do, if patients are doing well, let them kind of simmer on methimazole. But it is also important to remember that less than half of our pediatric patients will achieve remission and sustain that remission with treatment of antithyroid drugs alone. And about 35% of them will experience recurrence, even if they're able to get off of methimazole initially. So when do we think about other treatments? Really, I think about this in a few different clinical situations. And our two options right now are either radioactive iodine or surgery. So radioactive iodine is only offered in children who are older than 5 years old. The gland has to be somewhat modest as far as Graves' glands go, with no nodules, and it may be falling out of favor in some institutions. We tend to do less of it. I think that may be specific to our patient population. There is this concern of a risk of secondary cancers, although most of that literature is really based on the doses given for cancer treatment and not Graves' disease. So just be wary of that argument. And then I offer surgery really in if there's a patient preference, if they want quick resolution. So oftentimes when kids are going off to college on their own, they don't want to have to do frequent lab draws. If they have a structural lesion in the thyroid, so of course, if they have a discovered thyroid cancer, the whole gland is coming out, right? And thyroid eye disease. So thyroid eye disease is really a reason to think about surgery. It's rare in children. So many adults with Graves' disease will present with eye disease, but it's quite rare in children. And so it can portend a more aggressive disease. And I think it also portends a phenotype of where these kids just have more extrathyroidal manifestations, including anxiety, which is hard to quantify, difficulty concentrating, and kind of the more neurologic background of Graves' disease. And the thyroidectomy is really going to remove that antigen that the body is attacking, and stop the deposition of those complexes. So again, heal with steel. So plug for surgery as being the oldest form of the treatment of Graves' disease, and really I think about it in these different settings. That being said, this chart that you may not be able quite to see is the reasons that the patient was referred for surgery. And by far and away, it's that the patient gets tired of taking antithyroid drugs. And what that means can be different for different patients and different populations. So we tend to offer surgery sooner in the US as opposed to Europe, where they let patients go for many years. It's very common to have patients on for 5-10 years or more. How do I think about doing surgery for Graves' disease? It's all about the preparation. So when the patient is going to sleep, or when they're in the office as well, I'm looking with ultrasound. I want to know, how big is the gland? How vascular is it? Where am I going to put the incision? Many of these Graves' disease have these long holes, and so sometimes my incision's a little bit higher. I'm also looking for nodules, and I want to know if there's a thyroid cancer, for example, beforehand. I do treat with Lugol's or saturated iodine solution. The data is weak, but I anecdotally feel that it helps with vascularity, and it makes my surgery easier. You can buy it off of Amazon. So it's one of our nurses handles that coordination, and we start it 10 days prior. We have a standardized pre-anesthesia huddle wherein we get labs at a certain interval before surgery. Certain patients need an EKG or an echo, and we determine if there's any beta blockade needed. And then I continue their antithyroid drugs in consultation with our endocrinologist. Here's a case that we took care of not too long ago. This is a young man who presented with weight loss, tremor, anorexia, this muscle weakness and cramps. He was diagnosed with Graves with hypokalemia, so intermittent paralysis, hypokalemia. He was really intolerant of methimazole. He felt that it made him have fatigue and headaches and difficulty concentrating. He had a lot of breakthrough symptoms. And so he was referred to us in 2021 of February to consider either radioactive iodine or surgery. And so in our clinic, you see myself as a surgeon, you see our endocrinologist, Dr. Seeley, and then if you're there to consider radioactive iodine, we have our nuclear medicine physician Zoom into that room. So it's the patient and then the 3 physicians, our nurse coordinator, all together having this conversation, which I think the families really appreciate. And so when we look at this case, he is clearly not a great candidate for radioactive iodine. So he has very severe disease. He had a huge and hypervascular gland, and he was quite symptomatic. And one thing to remember about radioactive iodine is you really see the effects over 1 year. And so if you want rapid resolution, surgery is the way to go. Also, when you have a large gland, sometimes it takes more than 1 round of radioactive iodine, which was not a good solution for this patient. He did very well. He did need to be admitted to the pediatric ICU for an esmolol drip. And yeah, let's see. And then this is, sorry, I did not translate this, but this is just to outline what our preoperative, perioperative workup for these patients is. And it just helps us streamline to be sure that no matter who's taking care of the patient on the day of surgery, from an anesthesia or a surgical trainee or an endocrine standpoint, that we really have a roadmap and a game plan to follow to keep these patients safe, because they can act up on you. So few key points about Graves' disease. So extrathyroidal manifestations of Graves' disease, such as orbital disease or neurologic manifestations of disease, really may be best served by surgery. I think that decreasing blood in the operative field may facilitate our operation, and surgery is still a team sport. So it's important to remember the diagnosis of a toxic adenoma. We differentiate this both by our laboratory studies. So our antibodies for Graves should be negative, and we should see hyperthyroidism. Ultrasound will often delineate a nodule, and then this is where we get a nuclear medicine scan. And so I see a handful of these come through every year. They're always really fun cases. And very grateful patients, and really the work is done by our endocrinologist, who make the diagnosis on their thorough adherence to really going through this algorithmically and getting to the right diagnosis. Here is an admission of failure. So I am happy to be at a point where I can share this case, but this was the only recurrence I've ever seen or heard of after a Graves' disease. But a 14-year-old girl who initially had severe anxiety, mild thyroid eye disease, in the setting of Graves' hyperthyroidism. She elected for thyroidectomy, and she did really well for about 1.5 years. And then at about 1.5 years, she started having those same symptoms. She was very anxious, she was tachycardic, and she had biochemical evidence of something going on. She had recurrence of her Graves' disease. So we got labs which confirmed that, a thyroid ultrasound, and then an ultrasound guided FNA, which did indeed show thyroid. And essentially she had a focus of ectopic thyroid tissue, probably from endothyroglosal duct tract, or I just missed it during surgery. And we took out this additional focus, and then she did really well. And thankfully we're a few years out and she hasn't had any recurrence. But I was very grateful for my team to really do the workup and not ignore her and not think that, well, we took the thyroid out so it can't be Graves, because it turns out it can be. So that was a good lesson learned. And then another interesting case is this 23-year-old with a very complex medical history, including muscular dystrophy, end-stage cardiomyopathy. He was on a lot of anticoagulation, dual agent anticoagulation for his destination LVAD. He had hyperthyroidism, he was obese, and he had amiodarone-induced thyroiditis. Amiodarone-induced thyroiditis is really rare, but it does happen in iodine deficient regions, and even in North America, really it can happen in up to 3% of patients treated with amiodarone. In contrast to our other forms of hyperthyroidism, where we think of it as being a more female predominance, this is a more male predominance at a similar ratio of 3-to-1. And it's really hard to tell this from Graves' disease, except that the antibodies should be negative. So your TRAb antibodies should be negative. The first step in management is really stopping the amiodarone if possible. Some patients will respond to methimazole or glucocorticoids. This patient did not respond and unfortunately had to go on to thyroidectomy, which he tolerated just fine, but was a very interesting evaluation to work through. We did do an uptake scan to see, as he was clearly not an optimal surgical candidate, to see if there was any uptake, wherein we may think that radioactive iodine would have some benefit, but it did not have any uptake, and so we did not offer radioactive iodine. He went to surgery instead. Just in wrapping up here in these last few minutes, there are a lot of clinical opportunities for us to be investigative. And I am a clinician, and I also run a basic science lab. And these are problems that keep me up at night. I have a long family history of autoimmune thyroid disease, and I really think that by the time members of my family are thinking about thyroidectomy, I would love to see people like me, thyroid surgeons, not a part of that algorithm, right? And so we want to understand which children will fail management, and are there novel therapies that can really treat the physiology of the disease instead of acting at the level of the thyroid? Can we get to that autoimmune process, whether that's through immune modulation, the microbiome, novel therapies, but targeting further upstream, I think, is a really exciting area of investigation. And so I'm happy to have a lab, and we do some organoid work trying to develop healthy thyroid organoids. And we also are really interested in continuing our work in disparities to define these populations. So in conclusion, I think that pediatric thyroid care is similar but clearly distinct from adult pathology and management. Teamwork and our institutional advocacy, being at an institution that really values this multidisciplinary approach to our patients, is mission critical. And we get better together. So we review our cases, we measure our outcomes, we try to increase our volume when we can do it safely and with the same standards that we have always had, and we learn together. And that's why I feel very lucky to have what I think is the best job in the world, to take care of these kids and push forward the science and do it in a place where it's valued and supported. And so with that, thank you so much for inviting me. Feel free to reach out on WhatsApp, and a special thanks to our team and then to my mentors as well.
Professor Meister, thank you very much for this very interesting lecture. We will have Professor José Antonio Orozco. Hola, ¿qué tal? Buenas noches, doctor Orozco. Ya lo habíamos presentado. El doctor Orozco es el jefe del Departamento de Endocrinología del Hospital Infantil Federico Gómez. Muchas gracias por haber aceptado la coordinación esta noche. Y adelante, doctor, no sé si tenga algo que incluir en lo que ya la doctora Meister nos comentó en un panorama general de la cirugía de tiroides y además, pues si hay preguntas y algunos otros comentarios.
Mm, buenas noches a todos. Good night, Dr. Meister. That was very nice presentation. For me, that I am in endocrinology in pediatrics, you are make a very good presentation about what we do every day in Children's Hospital Infantil de México. So very nice. ¿Puedo hacer las preguntas en español para que
Sí,
todo... Sí, sí, sí.
tenemos traducción simultánea, no te preocupes.
Muchas gracias. Bueno, la verdad es que he leído las preguntas que le han estado haciendo durante toda la transmisión y hay unas preguntas muy adecuadas. Yo también las compartí y quisiera empezar a la doctora haciéndole la siguiente pregunta. En el rango de la endocrinología pediátrica hemos visto cómo aumenta la frecuencia de cáncer de tiroides en los niños. Entonces, quería preguntarle, y lo muestra muy bien en sus diapositivas, ¿a qué cree que se deba este aumento en la frecuencia de cáncer papilar de tiroides en la edad pediátrica?
Wow, if we could only answer that question, right? So first consideration is I do think that it is a true increase in incidence. And the reason I feel strongly in that opinion is that we are seeing not only an increase in tumors that are small, but also in tumors that are large. And so when we see large tumors also increasing, we can't explain that away as just increased detection. Sure, that's a piece of it, but really that should drive the small tumors. Now, what is driving this? I think that there are certainly environmental influences. Those may be psychosocial. I think that our children today, they have more stress. Socially, they have more stress. They spend less time outside exploring the world, getting their vitamin D, falling down, learning to cope. And so I think that stress and depression really affects our endocrine axis and may be leading to some endocrine dysfunction. I do believe that there are also likely things in our environment, whether that's PFAS or microplastics or a change in the microbiome. I don't know. That's one of the focuses of my lab. But I do also think that there must be something in the environment that is also driving this. It is interesting that we see more and more fusion mutations. We also see more and more concurrence of thyroid autoimmunity with thyroid cancer. And so it seems to be some type of interplay of the immune system.
So, thank you very much. That is something we are looking every day because we see more patients with this type of cancer. La siguiente pregunta es preguntarle, y lo mencionaba, si existía una relación entre las diversas alteraciones genéticas, llamemos oncogenes, y las características como la edad más temprana, la agresividad de la enfermedad, el tamaño tumoral y la metástasis y la multifocalidad, doctor.
Yes, I think we are just at the tip of the iceberg of really defining that landscape. What we know so far is that fusion mutations tend to be more aggressive, both by tumor size, younger age at presentation, as well as just bulky lymph node metastasis and pulmonary metastasis. BRAF valine 600E, which we think of as being a more adult type of mutation, there is literature on both sides of the story, actually. So when I see an older adolescent, 17, 18-year-old, 16-year-old female, really a decent post-puberty age with a veiling, and some of those kids, I'll actually think about offering a lobectomy if it's really a T1A or in certain circumstances a T1B disease. Where if I saw that same thing in a 6-year-old, even at the same mutation, I probably would be hesitant, right? Because we don't have great data about the genetic driver and multifocality within, but we do know that younger kids, and younger kids have different genes, do
Yes.
have a higher incidence of multifocality. So I think we're just missing the data, but I think it will come eventually.
Thank you very much, doctor. La siguiente pregunta habla mucho sobre el diagnóstico. Aquí continuamos con la BAF, la función a nivel de la tiroides. Y nos preguntan si este estudio solo se limita a la patología histológica y si también se pudiera hacer algún tipo de estudio molecular para estudiar y detectar la etiología del el cáncer de forma temprana. ¿Usted qué opina, doctora?
It's a great question. So I alluded to this, but we are very fortunate at my institution that when we obtain an FNA, we will bank an additional FNA pass for future molecular testing. And right now, commercially, so if we have a commercial insurance, they will only pay for that testing to be run if the FNA is inconclusive. Meaning that's in the gray zone. So if it's a definite benign or a definite malignant, most insurers will not pay for the molecular testing. However, at our institution, I can often make the argument that, hey, we need this even in our malignant patients because we need to be, we may want to change how we treat this patient, meaning offer a TKI. And so we are just for the past 4 to 5 years getting the data from that, but it's a real challenge in the sense that you have to think about collecting that extra specimen up front, and even then sometimes the quality doesn't work out, like the patient I mentioned where she has the Graves, etc. As an aside, if there's a background of autoimmunity, the molecular testing has a higher failure rate, just to put that out there. But it's really who's going to pay for it, because we're chasing our tail. No one will pay for it. Then we can't get the data to drive the payers. And so I think it's there. We just need some benevolence in getting it done.
Yes, true, true. And la siguiente pregunta que nos realizan es muy enfocada y yo creo que conocemos la respuesta, pero también dejarla muy clara. Si existe o tiene una utilidad el consejo genético para prevenir el cáncer de tiroides en los niños.
Yeah, so we see patients at multiple time points. And so we have a predisposition clinic at Stanford Children's. So these are kids who don't have a known thyroid problem, but maybe they have a genetic diagnosis associated with a thyroid problem, such as Dicer-1. That's probably the most common that I see. And they are seen by the predisposition clinic, and then they get their ultrasound and they come on to us. So Dicer-1 is a germline mutation. Dicer-1, it's a tumor susceptibility syndrome. Most often, these children will present with pleuropulmonary blastoma, ovarian or sex stromal tumors, cystic nephromas, but they can go through this march, basically, of thyroid hyperplasia, multinodular goiter, and then on to papillary thyroid cancer. And so we see patients from that standpoint. We also see patients who were diagnosed with thyroid cancer, then they were discovered to have a an odd genetic mutation or something that made us offer genetic testing. So we have found BRCA mutations. I have found familial adenomatous polyposis, so FAP, which then becomes very important for the whole family, right? So the whole family is then offered testing. And when I was a surgical fellow, there was a 20-year-old patient who I was seeing for a nosebleed. And I was seeing her for a nosebleed in the setting of end-stage liver disease. She had just been diagnosed with stage 4 colon cancer. And when I went to see her, I noticed that she had a scar on her neck. And it turns out that when she was about 6 years old, she had thyroid cancer. And, this is, now 20, almost 30 years ago. So we didn't know what we know now. No one offered her germline testing, but would she have had that? I bet her FAP would have been discovered. She could have gone on to surveillance for colonoscopy and potentially not experienced that colorectal cancer. So.
So that is very nice you share, because we see the same sometimes in the hospital when the patient arrive, and it's complicated to explain the reason of that kind of scarf or something. Voy a hacer en español, tenemos muchas preguntas sobre la influencia de la biología molecular y los genes en el cáncer de tiroides. Aunque también algo que yo veo aquí en las preguntas es algo si está relacionado con la carga viral, si hay algún, nos ponen, se piensa que en la tiroiditis la causa es viral. Si se investiga y determina la causa viral y si se debería utilizar la biología molecular, al igual que para el cáncer de tiroides. ¿Qué nos puede compartir, doctora?
No, I think I understand. I think the translation works. The question is that we just don't know the answer to that question. So one of the fellows in my lab looked at a population in the northeastern United States, both middle and post-COVID, right? Like, could this be viral induced inflammation that then leads to some immune dysfunction? And there was no direct correlation with differentiated thyroid cancer. There was a soft increase in Graves' disease, but that's a very small study. We are currently looking at that on a much larger basis, that question. But it's going to be very difficult to answer because we were very attuned to COVID for a little while. And the truth is that people get viruses all the time. And the way my body responds to RSV versus the way that your body responds to influenza, it may not be the virus, it may be our immune response to that, or the alteration, or some type of biologic mimicry. And so I think it's some immune dysfunction that may be virally mediated, but it may also come from other stressors on our axis. So
That is
I'm
very
interested in your thoughts, Dr. Orozco. Yeah,
yes.
on that question.
Yes, I think it was a difficult question because was a lot of things about thinking what they wanted to know, but it's difficult to say the answer in every kind of disease in endocrinology, in pediatrics. A lot of disease have relation with virus. Diabetes type 1, thyroiditis, thyroid cancer. But the question is, how much do we know to know more to help the patient? We know the treatment, but know the reason is very difficult. In diabetes type 1, that we see a lot of patients in the hospital, is really what was the reason? Infection, something in the environment. So it's a very difficult answer for the question. Tenemos otra pregunta muy específica en cuanto a la cirugía. Nos pregunta, le agradecen su presentación y quieren preguntar, en una cirugía o tiroidectomía, ¿cuál es la diferencia entre una población pediátrica y adulta? Y yo también quisiera si nos pudiera compartir eh, qué prefiere al operar a un paciente pediátrico, en un cáncer de tiroides, la hemitiroidectomía o tiroidectomía total. ¿Cuál es su opinión, doctora?
Yeah, so I think that structurally, they, the approach is not very different from a pediatric versus an adult patient. The complications have longer lasting consequence. So a nerve injury or hypoparathyroidism in a young child who has 80 plus years to live is something that weighs on me quite a bit. We also know that if we do a very comprehensive surgical procedure, we may be able to avoid radioactive iodine. And so that it's the yin and the yang, right, of balancing risk versus benefit, because our non-surgical treatments may have consequence as well. I follow the American Thyroid Association 2015 guidelines, which almost universally recommends total thyroidectomy for differentiated or medullary thyroid cancer in children. I will say that sometimes I break those rules. And when I do it, it is in a very bland, kind of almost an adult tumor. So we have that like 16-year-old girl, that 17-year-old, the 18-year-old who's still seeing a pediatric person, and it's a tiny tumor, less than a centimeter to 1.5. I haven't been convinced to do only lobectomy between 1.5 and 2.0, but we have a patient that we are discussing. So I do think that we will see more of a role for that. And what we really need is a way to offer surveillance for those kids, right? And so one of the challenges is that without a total thyroidectomy, it's hard to follow thyroglobulin, right? And other markers. But by leaving some thyroid in there, we may also really improve their quality of life. And so if we could solve the surveillance problem, I'd probably be more adept to offer lobectomy. But I do think, honestly, that there is a role for lobectomy. And I really think that this is where molecular testing will influence how we treat this. Because, for example, I had a patient who had a 1.1 or 1.2 centimeter lesion, but it was fusion positive. And so I told the family that I was not willing, even though she was older, I was not willing to do a lobectomy because I was so worried about multifocal disease, if not now, then in the future. And I thought that the burden of surveillance just wasn't worth it. And so we eventually decided on total thyroidectomy. She did indeed have multifocal disease. I took some ipsilateral nodes, and insofar, we have not treated her with radioactive iodine. So I feel very good about that choice. But these are the cases that keep me up at night, for sure.
Thank you very much. I want to make another question very personal for me. We have now this topic in endocrinology in pediatrics. What can you share about the transition when you have a pediatric patient and it's the moment to be adult? How do you make that transition? How you, in your experience in hospital, how do you send to the adult doctor? For example, a patient with thyroid cancer, what do you do? What is the most personal practice? How do you do the transition to the adult doctor?
Sure. So we have some hard rules. So under 14, they have to come to the ped side. Over 25, unless there's a really strong reason, such as that 23-year-old with the Beckers and who's on the destination LVAD, who's like basically lives at the children's hospital. So 14 and then 25. In between that, it really is patient specific. And so if they are part of the cancer predisposition or survivorship clinic, so all of their cancer care, maybe for their previous leukemia or immune syndrome, is done at the children's hospital. Those children often stay with us until they're the upper into their mid-20s, that 20, 22, 23-year-old, just because it really helps to facilitate communication. Other kids, when they're 17 and finish high school, their parents are pushing them to graduate from their PCP, take on their, take on their own medical. And that's a very logical time to transition to the adult side as well. We are fortunate to have an adult endocrinologist who has a special interest in young adult and pregnancy. And so almost all of my patients transition to her clinic from our pediatric endocrine clinic. So.
So that is very nice. Thank you.
Yeah.
We have problems, no problems, but it's difficult to send to a specific hospital that have that kind of attention in Mexico. So it's very nice. And we are working in all the pediatric endocrinology disease to make a nice transition. Otra pregunta de los doctores que están aquí con nosotros es un poquito enfocada hacia la tiroiditis de Hashimoto, y nos preguntan que en un paciente las causas de recurrencia de enfermedad, tanto de tiroides de Hashimoto como de Graves, ¿qué se pensaría? ¿Si hay una recurrencia por un tejido ectópico o es porque no se detecta la causa original?
This is Yeah, it's a challenge because we don't honestly know what makes the antibodies switch, right? So we don't know what triggers. I think there are definite genetic predispositions that will never change someone's genes. Well, I shouldn't say that because gene editing is all over the news, but it will be hard to convince people to do gene editing for a fairly benign disease in the scheme of things. But so I do think that there are genetic predispositions. It's going to be hard to change those. There are also patients that cross over, right? They have a presentation that looks more like hyperthyroidism, and then they develop anti-TPO antibodies and have more of a hypothyroidism physiology. And so I think that more and more it's important to look at all sets of antibodies, which is we're pretty comprehensive in getting that. And think of it more of as a spectrum of autoimmune thyroid disease than like they must fit in the Graves bucket, they must fit in the Hashimoto. I have also had one case of antibody negative Graves, so was Graves on pathology and all antibodies were negative. So there are probably things out there that we just don't have the testing for or don't understand yet.
Thank you very much. Hemos respondido más de la mitad de las respuestas, de las preguntas, perdón, realizadas. No sé si por el tiempo, y yo más bien quiero agradecerle a la doctora todo lo que nos ha compartido y pues esta invitación que nos hicieron. La verdad es que yo me voy satisfecho y con tareas para repasar, y muchísimas gracias. No sé si el doctor quisiera comentar algo más.
Sí, solamente agradecer tanto a la doctora Cara Meister de la Universidad de Stanford como al doctor José Antonio Orozco del Hospital Infantil de México por esta excelente presentación sobre patología de tiroides, que no es algo que todos manejemos. La verdad es que aprendimos todos bastante sobre el tema el día de hoy y bueno, pues siempre será un tema muy interesante y con cosas novedosas y pues no faltan también los temas de controversia. Muchísimas gracias, doctora Meister, muchísimas gracias, doctor Orozco, y muchas gracias a toda la gente que estuvo conectada en esta sesión internacional y nos vemos para la siguiente sesión. Muy buenas noches a todos ustedes. Hasta luego. Gracias.